We're going to talk here about neonatal jaundice. This is absolutely critical for the test. You're going to be asked a few questions about this, surely. And of course, if you work in pediatrics or family practice, this is something you need to be very acutely aware of. This is something that happens a lot, and you need to be aware of what normal neonatal jaundice is, or the physiologic jaundice, versus something more pathologic. So we're going to talk about bilirubin metabolism to refresh that. It's going to help us sort of get the idea of what the pathophysiology is, so some of these diseases make sense. We'll talk about physiologic jaundice. You definitely need to know the difference between the physiologic jaundice, which is the majority of jaundices in the newborn nursery, and then pathologic jaundice, which has a specific cause that needs to be treated. And then we'll also talk about indirect versus direct hyperbilirubinemia. This is just like in adults. You can have indirect hyperbilirubinemia or direct hyperbilirubinemia. The difference is in the neonates, you've got different causes, different diseases that can cause these. Then we'll talk about some causes of pathologic jaundice. And we'll talk about these in greater detail in subsequent lectures. So this is the bilirubin, I guess you could call it the bilirubin cycle. Some of the bilirubin is reabsorbed by the gut, so it does kind of make a cycle, but ultimately bilirubin stems from the red blood cells, just like in everybody else. Red blood cells, when they get old, they are destroyed by macrophages in the spleen. They break down into the heme, into the globin portions, and then the heme ultimately gives rise to the bilirubin. So let's look at this in some greater detail. So the first step is the red blood cell is broken down in the spleen, and the hemoglobin is going to be broken down into the globin protein, which is recycled, and then the heme portion. And that heme has iron, and then it's got a porphyrin. So the heme is then separated, the iron is taken off, and the heme then becomes biliverdin, and the enzyme that facilitates that process is called heme oxygenase, and that iron then can be recycled. Biliverdin then gets converted to bilirubin, and that's by the enzyme biliverdin reductase. The next step then is bilirubin gets taken up into the circulation, and it is subsequently bound to albumin. Now, some bilirubin will be free, but the majority of bilirubin, the vast majority of bilirubin, will be bound to albumin because bilirubin itself is not water soluble, so it needs to be bound to a protein in the blood. And we'll see when we talk about pathologic jaundice, as some of the pathologic jaundices, if there's not enough albumin in the blood, then you're going to have a lot more circulating free bilirubin, and that's going to come into play when we talk about bilirubin encephalopathy and kernicterus. So the bilirubin is transported to the liver, bound to albumin. The albumin dissociates from the bilirubin, and then the bilirubin enters the hepatocyte. And then the important step here, when we're talking about direct versus indirect bilirubin, is that the bilirubin is conjugated, has some sugar moieties that are added onto it, and that's by this enzyme UDP glutamyltransferase, or it's also called UGT1A1. And this conjugates the bilirubin, so instead of just regular old bilirubin, you have conjugated bilirubin. The conjugated bilirubin is more water soluble, and so this is what's going to go into the biliary tract and ultimately into the intestines. So the conjugated bilirubin is transported out the hepatocyte into the biliary canaliculi by a protein called multidrug-resistant protein 2. I wrote it here as MDR2, but it's usually they abbreviate it as MRP2, so it's multidrug-resistant protein 2. And this is what transfers conjugated bilirubin into the biliary tract. And then from there, it goes into the intestine at the duodenum and ultimately gets deconjugated at the terminal ileum. Some bilirubin will return to the liver, and that's the hepatoportal circulation. The bilirubin that does not return to the liver will get converted by bacterial enzymes into stercobilin, which is passed out in the feces, or urobilin, also urobilinogen, which is what it is initially. And then the urobilinogen goes into the bloodstream and then ultimately is excreted to the kidneys as urobilin. And that's what gives urine its yellow color. So these are your pigments for the feces and the urine. So here's your process. We went through all of this. So physiologic jaundice, you need to know what this is. This is absolutely critical because you will be given a question on the USMLE, and it may be physiologic jaundice, but they want to try to sideline you and make you think you need to treat it. Virtually all babies will have some degree of physiologic jaundice. You may not notice it because it might be really slight, but most babies will have an elevation of bilirubin that may be noticeable as jaundice. And this occurs as the baby transitions from reliance on the placenta to clear bilirubin onto the baby's own hepatic system. And the physiologic jaundice occurs because the baby's system is not quite ready to deal with the bilirubin yet. And there's a few things that happen. First off, some of the fetal hemoglobin, it's not quite as stable. That's going to break down a lot faster when the baby transitions into neonatal life. And then also that enzyme, the UDP-GT, that is not quite in sufficient amounts necessarily yet at the very first day of life, second day of life, and so that also can lead to a higher bilirubin. And then also the intestines are not moving quite as fast as they will by the end of the week or week 2, and so that's going to slow things down and increase the enterohepatic reuptake of the bilirubin. So there's lots of different factors that lead to a baby's diminished ability to clear bilirubin, but that's normal, and those things go away with time. So physiologic jaundice, first off, important to know, is never visible on the first day of life. If you ever see jaundice in a baby in the first 24 hours after birth, it is probably a hemolytic process. Secondly, the total serum bilirubin may rise up to 5 milligrams per deciliter per day up until day 3 to 5. Usually it's not that much, but it can rise up until that much up until day 3 to 5. So while the baby's in the hospital, you should take a bilirubin after birth, day 1, day 2, so you can plot it out and see where the baby is falling. The conjugated bilirubin will never pass 2 milligrams per deciliter or 20% of the total serum bilirubin, whichever is lower. So let's say that the baby has let's say that the baby has a total serum bilirubin of 4. Then the cutoff for conjugated bilirubin is going to be 0.8 because that's 20% of 4. So anything above 0.8 is going to be pathologic because the conjugated bilirubin is more than 20% of the total serum bilirubin. If the total serum bilirubin is beyond 5, then 2 milligrams per deciliter is the cutoff for conjugated bilirubin, where it becomes pathologic. Okay, so hopefully that makes sense. 2 milligrams per deciliter is not always the sharp cutoff for conjugated hyperbilirubinemia. 20% of the total serum bilirubin. If the total serum bilirubin is below 5, that can be the cutoff as well. The total serum bilirubin will peak around day 3 to 5. Problem is, baby's typically not in the hospital around then. And then visible jaundice, if it's present, will resolve by 1 week of age in a full-term baby, and typically by 2 weeks of age in a premature infant being defined as less than 37 weeks of gestation. And that the reason it takes longer in the premature infant is for all of those reasons I described, that the baby's liver and GI tract still needs a few more days to come to maturity, even after the baby is born. So here's what neonatal jaundice looks like. You can see kind of a gold tinge to the baby. And not all neonatal jaundices look alike. It might be really obvious. It might just be really slight. Just depends. See, this baby, a little less noticeable than the first one. Good place to look is the eyes. So here you know it's scleral icterus. That's always jaundice. And particularly when you're dealing with darker skinned babies, the eyes are going to be a good place to look. So pathologic jaundice is any jaundice that doesn't satisfy the criteria for physiologic jaundice. So this is visible jaundice on the first day of life. It is a total serum bilirubin that rises faster than 5 milligrams per deciliter over a 24-hour period. It is a conjugated bilirubin that surpasses 2 milligrams per deciliter, or 20% of the total serum bilirubin, whichever is lower. So again, giving an example, if the baby has a total serum bilirubin of 3.8 and a conjugated bilirubin of more than 0.76, that would be considered pathologic because that's more than 20%. But like I said, if the total serum bilirubin is beyond 5, then we just use a cutoff of 2 milligrams per deciliter. We don't take 20% for that. And then if the total serum bilirubin continues to rise after day 5, that's also considered pathologic. So if any of these criteria are satisfied, it's considered a pathologic jaundice. Now, one of the most important things that you're going to be responsible for knowing as far as jaundice goes is determining whether it is a direct or indirect hyperbilirubinemia, and then from there, particularly for the indirect hyperbilirubinemias, coming up with a diagnosis. So when you're talking about the direct hyperbilirubinemia, you really have to go on the history, on any additional symptoms that might be present. Was the baby possibly exposed to infection? Does the baby have any signs of genetic or metabolic diseases? Those sorts of things. Does the baby appear well or ill? So that's going to be a little bit more difficult to ascertain the cause, especially on just your basic step 2 and step 3 questions. When it comes to indirect hyperbilirubinemia, it's a little bit easier. So with an indirect hyperbilirubinemia, there are 2 things you really need to get, and that's a direct Coombs test and a reticulocyte count, and you can probably even add on to that a hematocrit. That's going to tell you 2 things. It's going to tell you whether or not there is hemolysis going on, and it's going to tell you if there is hemolysis, whether or not that hemolysis is autoimmune, so an isoimmunization like Rh isoimmunization or an ABO incompatibility, or if it is a non-autoimmune hemolysis, and that would be things like spherocytosis or elliptocytosis, some of those things that you see more in adults as well. Typically, these non-autoimmune hemolytic diseases don't present in newborns, but they can. So I'm just including these in here for completion's sake. Okay, so here's a few examples to sort of nail down this pathophysiology here. So Rh incompatibility, we'll go into this in more detail in the indirect hyperbilirubinemia section, but this is an attack on fetal red blood cells by maternal anti-Rh antibodies, typically anti-D antibodies, which is the major antibody that causes problems with Rh incompatibility. There's some minor ones, but for the USMLE, be aware of the anti-D. That's usually what they're referring to when they're referring to Rh incompatibility. This happens if the mother is Rh negative and has previously carried an Rh positive fetus and now, and so since then, she's created anti-Rh antibodies, and now she's carrying another Rh positive fetus, and now those anti-Rh antibodies can cross the placenta and attack the baby's red blood cells. So if mom is Rh negative, and it's her first pregnancy with an Rh positive fetus, even though there is exposure to blood, she's not going to create the antibodies to attack that fetus. But if she has had a pregnancy with an Rh positive fetus, and then she has another pregnancy with an Rh positive fetus, now the antibodies are there and it can attack that fetus. Now we can prevent this, but this is something to keep in mind, because if the mother didn't receive adequate care, then this can come into play. So as far as diagnosing this, we're going to try to stick to the pediatrics here rather than the OBGYN. For the baby, it's going to be that direct Coombs test. The direct Coombs test will come out as positive. Treatment, this really, in the United States, you really should be treating this preventatively with good obstetrical care. You should be, and this is part of any prenatal visit. You should be doing Rh titers, anti-Rh titers on Rh negative mothers, so that you know whether or not you need to administer Rh immune globulin, and that's going to help you prevent this from happening in future pregnancies. But from the pediatric side, if you have a baby who was delivered with Rh incompatibility, then the treatment is going to be phototherapy and exchange transfusion. Exchange transfusion more so in extreme cases. We'll talk about this in greater detail in the indirect section. ABO incompatibility is pretty similar, but it's not as severe. It's more common than Rh incompatibility, but it's less common to be a problem. So this would be exactly how it sounds. So mom has a different blood type than baby, and she's got antibodies that attack baby's blood cells. So let's say mom has type O blood, baby has type A blood. Mom has anti-A antibodies, which will cross the placenta and attack baby's red blood cells. It's very rare for this to be severe, and so usually when you see severe immune-mediated hemolysis, it's going to be the anti-Rh, the Rh isoimmunization, but this is another possible way to have an immune-mediated hemolysis. And just like in Rh hemolysis, Rh isoimmunization, you're going to get a positive direct Coombs test. So for diagnosis, it'll be positive direct Coombs test. You should also note that there will be an ABO incompatibility with mom, so baby certainly shouldn't be type O blood. Baby will be either A or B or AB, and mom will be incompatible with that. You should rule out Rh incompatibility if necessary, but usually this is pretty clear, and it's very rarely as severe. The treatment for this is to monitor the baby, and then UV phototherapy is necessary. Crigler-Najjar syndrome is the absence of that enzyme, that UGT1A1, and that is the enzyme that's responsible for conjugating bilirubin into conjugated bilirubin. And there are various degrees of absence or deficiency of this enzyme. So in Crigler-Najjar syndrome type 1, that's a complete absence of UGT1A1. And so these babies are completely unable to conjugate bilirubin. And so this is going to cause a severe indirect hyperbilirubinemia, and ultimately this is going to require liver transplant. Type 2 Crigler-Najjar syndrome, these babies are just deficient in this enzyme. So they'll probably develop an indirect hyperbilirubinemia, but it won't be as severe, and with time it will get better because you don't need quite as much of this enzyme as you have. So even though they're deficient, it will typically be enough as they get older. So this will cause also an indirect hyperbilirubinemia, but you can differentiate type 1 from type 2 because in type 2 you can give the babies phenobarbital. Phenobarbital will induce this enzyme. And so in these babies, when you give them phenobarbital, it should reduce their total serum bilirubin by around 30 to 80%. Of course, if they don't have any of this enzyme, then phenobarbital is not going to do anything because there's no enzyme to stimulate. Usually type 2 Crigler-Najjar syndrome is not diagnosed in the neonatal period because this is so this deficiency is so minute that it doesn't really result in symptoms. But type 1 is the one you need to be aware of. This is a total deficiency, and this always will require transplant. Dubin-Johnson syndrome is a conjugated hyperbilirubinemia. So this is due to a mutation of that MRP2 protein, and that's responsible for transporting the conjugated bilirubin out into the biliary canaliculi. This is an inherited disease. It's autosomal recessive. Again, this is another one that's typically asymptomatic. But when it does present, it's usually during the teenage years. But it can present in babies, so I want to include this because this is all part of our differential here. What I'm trying to nail down here is sort of this pathophysiology, so you kind of get an idea of where things can go wrong. This can be diagnosed in the urine. There'll be an elevated ratio of the coproporphyrins, and I doubt the USMLE will ask you about this, but that's technically how you would diagnose Dubin-Johnson syndrome. And treatment is symptomatic, but usually it is not necessary because this doesn't really cause any severe symptoms. Biliary atresia is a big one. So this is very important. This will always present in babies. So this is not like Dubin-Johnson syndrome where you got a 12-year-old presenting with biliary atresia. That doesn't happen. With biliary atresia, you have a defect of the biliary tract, and so that's going to cause problems early on. And usually it's so severe that you can't even get the bile from the liver into the intestine. And so this is obviously going to be a conjugated hyperbilirubinemia because you can conjugate the bilirubin, but then the conjugated bilirubin will not be able to get to the intestine, and so it's going to build up and get absorbed into the bloodstream. No single test is diagnostic for biliary atresia. You kind of have to suspect it based on labs, which show you a conjugated bilirubin or conjugated hyperbilirubinemia, kind of excluding other possible causes. Sonography, you'll get a triangular cord sign in some cases, a HIDA scan. But the best way to diagnose this is when you really suspect biliary atresia, you go in for an operation because you think you're going to have to do an operation to treat this baby. You do an intraoperative cholangiogram, and that is the best, most accurate way to diagnose biliary atresia. And the procedure you're going to do after you do that intraoperative cholangiogram and you diagnose biliary atresia is called a Kasai procedure. What you're basically just doing here is taking a part of the intestine and sewing it up against the porta hepatis. And this should be performed early, within 8 weeks of age. If it's performed after that, it really doesn't have good results. If it's performed before that, it has much better results. So you can see the importance of diagnosing this ASAP. Again, we're going to go in greater detail into all of these disorders in the subsequent sections. I just wanted to give you sort of an introduction to some of the major causes of neonatal jaundice. And then one more. Okay, neonatal hepatitis. So this is a disease of the liver tissue itself. It's an infection. It's either congenital or it's acquired early. These babies will appear ill and they'll feed poorly. So this is going to be another conjugated hyperbilirubinemia, but unlike the biliary atresia, these babies will appear ill. They tend to be lethargic and hypotonic. They'll also have dark urine. but the meconium in stool is typically unremarkable. It's not a colic stool like you would see in biliary atresia or the extrahepatic hyperbilirubinemias. For diagnosing neonatal hepatitis, you just need to get an array of titers for specific pathogens, particularly viral pathogens, HSV, enteroviruses, CMV. Viral causes are the most common, but there are also bacterial causes as well, syphilis, E. coli, some other ones, group B strep. And then the treatment is going to be based on the specific pathogen, of course, fluids and adequate nutrition, and then supportive care, making sure that you supplement the baby with medium-chain triglycerides and vitamins A, D, E, and K. So like I said, we're going to go over all this stuff in subsequent sections. So if you feel like I didn't explain any of this in really good detail, you're right, I didn't. I just want to sort of give you an introduction here. So I will see you in the next section.